We'd now like to move into the discussion. Dr. Shom Goel of the Peter MacCallum Cancer Center in Melbourne will now discuss the last two abstracts.
Well, thank you. Good morning, chairs. Good morning, everyone. It's my pleasure to be here with you today to discuss the last two very interesting and very beautifully described projects that we've just heard. These are my disclosures. So the last two studies that we've just heard are obviously very different, but they're also linked because they both address this very common and very complicated clinical challenge of CDK4/6 inhibitor resistance. Dr. Garducci's study in the lab is really trying to get at the hows and the whys of CDK4/6 inhibitor resistance. And Dr. Mayer's clinical trial is exploring therapeutic strategies that we might try once that resistance has developed. Both of the studies, I think, also raise some interesting questions about whether or not there are clinically meaningful differences between different CDK4/6 inhibitors, and I'll come to that later in my talk. But let's start in the lab and review the experiments of Dr. Garducci. So this is an in vitro study using the MCF7 breast cancer cell line, and here the authors have introduced a DNA barcode library into their MCF7 cells, labeling each cell with a unique barcode. They then expand those cells up, giving rise to multiple barcoded clones, each of which is derived from a single cell. And they then treat those clones with vehicle control, palbociclib, or abemaciclib until the point of observing drug resistance, which they define as growth of cells in a relatively high concentration of drug of 1 micromolar. And more than this, they do the whole experiment with or without the concomitant expression of a mutant estrogen receptor, which they achieve using this exogenous doxycycline-inducible construct that expresses the ESR1 gene with a Y537S mutation. So I think one of the key questions that's asked in this study is that about clonal selection. When you treat a breast cancer with a CDK4/6 inhibitor, do all the cells respond and then somehow start growing again? Or are there specific cell clones within the tumor up front that are somehow non-randomly predestined to acquire or be resistant to the drug? This is a question that's actually been looked at a little in the clinical realm with whole exome sequencing from serial samples in the feline clinical trial, but I think those of us in the laboratory world have been eagerly awaiting a more granular experimental approach to answer this question as we're seeing today. So if we start by looking here, you'll see the distribution of the different barcodes, meaning the different cell clones, in each of the drug-resistant cell populations. And the fact that the 3 replicates in each condition have similar clonal composition, firstly, that's striking, and secondly, it strongly suggests here that the selection that we're seeing is not random, but or stochastic, but rather that certain cells are specifically primed to grow in the presence of these drugs. If we look at what the Y537S mutation does, the first thing we'll see is that the clonal composition of the ESR1 wild type and ESR1 mutant cells is actually quite different, even in the cells that are growing out of drug. And I think that's quite interesting because what it tells me is that an ESR1 mutation may change the relative fitness of these cells, and perhaps ESR1 mutations could therefore change the entire clonal composition of a tumor. Those same differences were also seen when comparing wild-type and mutant palbo-resistant cells, and to some extent when comparing wild-type and mutant abema-resistant cells, but the authors do point out that the differences here are less striking. And I think that specific point about abema then prompted them to look for other differences between palbociclib and abemaciclib-resistant cells, and they described to us different transcriptional profiles between the abema and palbo-resistant cells, and also a differential degree of cross-resistance, such that the palbociclib-resistant cells were still somewhat sensitive to abema, but the reverse was not the case. So what can we make of this experiment and this data? I think one key takeaway here is that acquired CDK4/6 inhibitor resistance may at times occur through this mechanism of clonal selection. And this, if it's true, it really matters, because if we have a way of identifying those clones up front and targeting them, it might provide us with strategies to prevent the emergence of resistance. And therefore, it really begs the question, what is different about these clones? Do they have a specific genetic alteration that confers the resistance? Or if not, could they be epigenetic clones? Do they have a specific transcriptional program that predestines them to resist CDK4/6 inhibitors? And if that's the case, is that transcriptional program fixed, or is it something that's dynamic? And these are the kinds of questions that we can answer these days using modern lineage tracing tools such as single-cell barcoding using expressed barcodes. The ESR1 mutation data, it's also interesting. To me, one of the most interesting points there was how dramatically the mutation altered the clonal composition of the cell population at baseline. But of course, what we all know is that these mutations also dramatically change sensitivity to various endocrine therapies. And I think what I would really like to see here is to see these experiments repeated in the presence of combined CDK4/6 inhibition and endocrine therapy, so we can see the impact of those mutations in that context. And finally, when we think about the differences between palbociclib and abemaciclib, I think we need to be careful here in how we interpret this data. It is certainly possible that abemaciclib is working here as a quote-unquote different drug. We all know that it has some other putative kinase targets above palbociclib. But it's also possible that what we're seeing here is a reflection of the fact that these drugs have different potencies for inhibiting CDKs4 and 6. Abema is a much more potent inhibitor, and so the cells that are being treated with 1,000 nanomolar of abema are under a more extreme degree of selection pressure than those in 1,000 nanomolar of palbo. And indeed, the trajectories on this UMAC plot suggest that this issue of selection pressure with potency may indeed be playing a role. And of course, the caveat which Dr. Guarducci has already mentioned is that so far we are only seeing data from one cell line. And I think this idea, this hypothesis would be greatly strengthened if we were to see it reproduced in other cell line models, or even if we saw it in vivo. So now we'll switch gears and let's discuss Dr. Mayer's presentation and the results of the PACE study. This was a study for patients who have hormone receptor positive, HER2 negative advanced breast cancer, all of whom had benefited from, but then developed disease progression on a combination of a CDK4/6 inhibitor with endocrine therapy. I'm showing you the characteristics of the patients and tumors here, but most importantly, please note that in 90% of patients, the prior CDK4/6 inhibitor was palbociclib. The majority of patients had been on that drug for more than a year, and that in 90% of patients, they went straight from their palbociclib-containing regimen onto the study. And as you saw, participants were randomized into these three groups: fulvestrant with continuation of palbociclib, or a triplet arm where the anti-PD-L1 antibody avelumab was added. And I think the PACE trial really addresses what I think is a really important and poorly understood issue. When we treat luminal breast cancers, we use CDK4/6 inhibitors together with endocrine therapy. And really the key question, I think, for the field right now is, when resistance develops, why does that happen? It reflects a breakdown of the synergy, but we don't really know what has gone wrong. And the question that the PACE trial is asking is, can we fix that breakdown by simply changing one part of the treatment regimen and keeping the other one going in the background? And as we saw, in PACE, it seemed that that idea or that strategy didn't seem to work. And it thus seems that pretty clear that we cannot recommend the use of palbociclib beyond progression on palbociclib as a routine strategy for clinical practice. But what does that mean? Why does that mean the whole hypothesis about continuing CDK4/6 inhibitors beyond progression is wrong? Are these resistant tumors just filling up with those resistant clones, such as those that Dr. Guarducci described, and they just don't care about further palbociclib? Because if that was true, we then need to reconcile the results of PACE with the results of the MAINTAIN trial, which was a trial similar in many respects, different in some, looking at the efficacy of using ribociclib after progression on a CDK4/6 inhibitor. Of course, the key difference between trials, amongst others, is that PACE is essentially a study of palbo after palbo, whereas MAINTAIN is a study of largely of ribo after palbo. We can only speculate if that has anything to do with the differences we see here. You know, Dr. Garducci showed us some data with a different drug that there may be sometimes differential cross-resistance between CDK4/6 inhibitors. Could it be that there's something beneficial about switching CDK4/6 inhibitors? What would happen if we did it the other way around? What would happen if we did a study of palbociclib after ribociclib? We simply don't know. So does that mean we should or we shouldn't be using CDK4/6 inhibitors beyond progression in clinical practice? Well, as Dr. Mayer pointed out, and I would really sort of emphasize here, we have to remember that both PACE and MAINTAIN are small trials. There are imbalances in the patient characteristics, first of all, between the trials, secondly, within the arms of each trial, and thirdly, in the performance of the control groups in each study. So trying to compare them and make meaningful conclusions is very tricky. And I'd suggest that we should await the results of these ongoing randomized trials, some of which are much larger, and two of which utilize abemaciclib, a drug which Dr. Garducci suggested might have activity in palbociclib-resistant disease, and for which we already have some non-randomized published data suggesting it has activity after progression on other CDK4/6 inhibitors. And we also have to note that even if a day comes where we do decide that continuing these drugs beyond progression is a reasonable strategy, we're going to have to choose when to deploy that strategy while simultaneously considering all the other drugs that are coming up in this therapeutic landscape. And for some of these drugs, it will be important to ask whether continuing a CDK4/6 inhibitor beyond progression is going to improve their efficacy as well. So finally, let's turn our attention to this triplet arm in the PACE study, which was certainly interesting. I mean, the headline is that there's no significant improvement in PFS or OS with the addition of avelumab. However, there is this intriguing trend to a slight improvement in median PFS and a slightly bigger improvement in median OS with the addition of avelumab. And I will dwell on it for a moment because it brings up a scientific point that is worth discussing. And that point is that there is strong preclinical rationale for combining CDK4/6 inhibitors with immune checkpoint inhibitors, given that CDK4/6 inhibitors have been shown to promote anti-tumor immunity. And I think specifically relevant to this context is their capacity to potently suppress the immunosuppressive regulatory T cells and to promote CD8 T cell differentiation towards a more memory or stem-like state. And this is the kind of phenomenon that gives the immune system stamina to go the long haul. And in keeping with that, I'd like to show you this table where I'm demonstrating that in a number of randomized CDK4/6 inhibitor trials now, we've seen a similar signal to what we've seen in PACE, and that is that the numerical improvement in progression-free survival is smaller than the numerical improvement in overall survival. And this is what sometimes is referred to as a carryover effect. And I'm going to speculate without any evidence to support me that this might in fact reflect the immunomodulatory properties of these drugs. What was also quite interesting, as Dr. Mayer discussed, was the toxicity that we saw with the triplet, because there were very few immune-related adverse events seen with palbo, fulvestrant, and avelumab. And this stands in contrast to previous studies where CDK4/6 inhibitors have been combined with anti-PD-1 antibodies. And it does open a question, which we can't answer today, as to whether there may be a differential toxicity profile between a PD-L1 and a PD-1 combination. So to conclude, I think these two studies have opened my eyes, and I hope open your eyes as well, to a number of important questions in this field. And they give us a lot to consider regarding directions for future research. First of all, I think we have a strong impetus now to do a very detailed assessment of this phenomenon of clonal selection. And this is something that we can do with more in vitro experiments in animal models, but also in clinical material. Secondly, and I think this is probably the most critical thing for me, we need to better understand how the CDK4/6 and endocrine receptor pathways truly interact and how resistance represents a failure of that synergistic interaction. Of course, we wait the results of the ongoing trials, the bigger trials of CDK4/6 inhibition beyond progression. And I think that the data from PACE, in my opinion, does at least reopen the discussion about whether we can use the immunomodulatory properties of CDK4/6 inhibitors to help benefit our patients. And underscoring all of this, we are going to be continually harassed by this question: are all CDK4/6 inhibitors the same or not? And the good news is that if you stay in this room at 11 o'clock, there'll be a debate devoted to that entire subject. So with that, I'd like to thank you for your attention and hope you enjoy the rest of your time in San Antonio.
Thank you. Okay. I'd like to again thank our last two speakers for their thought-provoking presentations and Dr. Goel for his insightful discussion.